Welcome. Today, we're diving into a rare but significant lung condition called pulmonary arteriovenous malformation, or AVM. We'll explore what it is, what causes it, how it affects the body, and what can be done about it. So, let's begin this journey into understanding pulmonary AVMs. What causes a pulmonary AVM? Well, in most cases, pulmonary AVMs are congenital, meaning a person is born with it. They often occur in individuals with a genetic condition called hereditary hemorrhagic telangiectasia, or HT, also known as Osler-Weber-Rendu syndrome. However, pulmonary AVMs can also be acquired, although this is less common. Acquired causes might include trauma, liver disease, or even certain lung infections, so the root cause can vary, but it primarily involves abnormal blood vessel development or damage. To understand pulmonary AVMs, we need to look at the normal process of blood flow in the lungs. Normally, blood travels from the heart to the lungs through pulmonary arteries. In the lungs, these arteries branch into smaller capillaries where oxygen is picked up and carbon dioxide is released. Then, the blood flows into the pulmonary veins and back to the heart. In a pulmonary AVM, this capillary bed is bypassed. An abnormal connection forms directly between an artery and a vein in the lung. This means blood bypasses the capillaries and doesn't get properly oxygenated. Furthermore, this direct connection allows clots and bacteria to bypass the lung's filtration system and travel directly to the brain or other organs, potentially causing serious complications. Pulmonary AVMs are relatively rare. The exact prevalence is difficult to determine, but studies suggest they affect roughly 1 in 5,000 to 50,000 individuals. However, the prevalence is much higher in people with HT, where it can affect up to 50% of individuals. Because HHT is often undiagnosed, many pulmonary AVMs may go undetected. It's important to note that this condition affects both men and women equally. Many people with small pulmonary AVMs have no noticeable symptoms. However, larger AVMs can cause a range of issues. Shortness of breath, especially with exertion, is a common symptom. You might also experience fatigue, chest pain, or coughing up blood. In more serious cases, pulmonary AVMs can lead to strokes or brain abscesses due to the unfiltered blood reaching the brain. Sometimes, a bluish discoloration of the skin, called cyanosis, may be observed, particularly around the lips and fingertips, indicating low oxygen levels in the blood. Diagnosing a pulmonary AVM typically involves a combination of imaging and clinical assessment. A chest X-ray may initially suggest the presence of an abnormality, but a CT scan of the chest with contrast is the gold standard for confirming the diagnosis. This detailed scan can clearly show the abnormal blood vessel connections. A pulmonary angiogram, where dye is injected into the pulmonary arteries, can also be used to visualize the AVM. Additionally, pulse oximetry or arterial blood gas tests can help assess the oxygen levels in the blood, which are often reduced in patients with significant AVMs. Pulmonary AVMs can be classified based on their size, number, and complexity. They can be single or multiple, and their diameter can range from a few millimeters to several centimeters. Complex AVMs may involve multiple feeding arteries and draining veins, making them more challenging to treat. Another way to classify AVMs is based on their association with HT. They can be categorized as HHT-related or non-HT-related, as this distinction can influence treatment and management strategies. The primary goal of treatment is to prevent complications such as strokes and brain abscesses. The most common treatment is embolization, a minimally invasive procedure where a catheter is guided through a blood vessel to the AVM, and coils or plugs are deployed to block the abnormal connection. This redirects blood flow to the normal capillary beds. In rare cases, surgery may be necessary to remove the AVM. Following treatment, regular monitoring is essential to ensure the AVM doesn't recur or new AVMs don't develop. Patients with HHT require lifelong surveillance for AVMs in the lungs, brain, and other organs. While we can't prevent congenital pulmonary AVMs, early detection and management, especially in individuals with HT, can significantly reduce the risk of complications. Genetic counseling can be helpful for families with a history of HT. Avoiding activities that could increase pressure in the lungs, such as heavy lifting or straining, might be recommended in some cases, but this is usually secondary to definitive treatment. The prognosis for individuals with pulmonary AVMs is generally good with appropriate treatment. Embolization is often highly effective in closing the AVM and preventing complications. However, lifelong monitoring is necessary, particularly in those with HHT. As new AVMs can develop, research continues to focus on improving diagnostic techniques, refining embolization procedures, and understanding the genetic basis of HHT to develop targeted therapies. There's ongoing research of the use of medications like bevacizumab, an anti-VEGF agent, to potentially reduce the growth and formation of AVMs in patients with HHT. This shows great promise for future treatment options. Thank you for joining us on this exploration of pulmonary AVMs. We hope this information has been helpful.